Director of Health, Dr. Ronald Lam, and Chief Executive of the Hospital Authority, Dr. Libby Lee. Professor Lo will say a few words, and then the floor will be open for questions. Professor Lo. Already? Secretary will take the floor. Citizens of Hong Kong, friends of the media, the Chief Executive delivered the Policy Address 2025 yesterday, and today we'd like to further brief you on healthcare-related initiatives, and I'm joined by the Bureau, the Department of Health, as well as Hospital Authority. The theme of this year's policy address is deepening reforms for our people, leveraging our strengths for a brighter future. Now, there are two main axes, namely livelihood and the economy. President Xi Jinping has remarked that one of the most important indicators for the happiness of our people is health. If health is compromised, everything else will be meaningless. Health is of utmost importance, and that is why health forms the core of people's livelihood as well as the cornerstone of our economic development. To echo this year's policy address, there are 7 major areas in terms of healthcare initiatives, and I'll go through them one by one with you. First, the Hospital Authority forms the core of Hong Kong's public healthcare system. It is also the safety net. The government will continue to enhance public healthcare services. The Hospital Authority will enhance safety, quality, and efficiency of public healthcare services. A committee has been set up to advance the reform of governance and accountability. In order to dish out subsidies in a more precise manner and to make sure that those in need will receive timely and appropriate treatment, we will take forward the public health care fees reform, and we will also set up a dedicated team and upgrade the electronic systems to process applications for medical fee waivers to make sure that no one will be turned down for treatment because of lack of means. At the same time, we will also review the charges and positioning of non-subsidized services so as to offer additional options for those who can afford these services. The third point is that we will continue to promote international hospital accreditation. We'll also set up stroke centers and integrated cardiovascular diseases centers so as to improve treatment efficacy. Fourthly, we'll also advance the international hospital accreditation program so that at least one hospital of these 7 hospital clusters, respectively, will be covered by the program. In the past 2 years, we have successfully improved the waiting time for the specialties of medicine and orthopedics as well as ENT. In the coming year, we will continue to make improvement on the waiting time for the specialty of surgery, and that it will be shortened by 10%. That is about 10 weeks. We understand that there is a huge demand for ophthalmological services. We will continue to enhance our services, including a training program for nurse-delivered intravitreal injection. We will also provide or establish a high-capacity ambulatory cataract surgery center. We will also upgrade comprehensively the degenerative knee joint management program so as to enhance the mobility of our patients. We'll also introduce digital pathology technology as well as the application of AI in the clinical process so as to enhance our service efficiency and clinical accuracy. We will also apply AI in other clinical processes such as the write-up of reports so as to enhance efficiency. We also want to enhance patient experience. We want to make sure that the patient's needs are met. This under the principle of patient-oriented services. We'll optimize service workflows by establishing dedicated care counters so as to provide better experience for the elderly, people with disabilities, as well as pregnant women. Under the optimized service workflows, they will be given priority throughout the whole process, including follow-up appointments, registration and payment, etc. We will also make use of AI-powered interpretation tools so as to improve communication with patients of ethnic minority groups. Next, let me turn to healthcare manpower development. In last year's policy address, it was announced that the government would support the establishment of the third medical school, and that in Ngaotown Mei Yuen Long of Northern Metropolis a site has been set aside for the establishment of this new medical school, as well as the new teaching hospital. The task group on new medical school completed an overall assessment on the proposal in the past year, in particular in relation to the positioning of this new school, the enrollment process and manpower, etc. The task group is now proceeding with an in-depth study at the next phase, including funding arrangements and financial viability. This task force will continue to maintain impartiality and professionalism in taking forward the assessment process, and that final recommendations will be made to the Chief Executive within this year. We also support the hosting of national or international medical and healthcare conferences in Hong Kong, leveraging on our world-class professional standards and extensive experience in international collaboration. We can facilitate further exchanges with mainland and overseas counterparts. And this includes the World Cancer Progress as well as the National Chest Pain Center Congress. In order to further promote exchanges with healthcare professionals around the world, the Hospital Authority will launch a talent chain project. This will provide a platform for personnel in our public healthcare system to get their hands on the frontier technologies. It will also promote collaboration and innovative applications, as well as commercialization of the research outcomes.
In terms of the strengthening the primary health care, we are strengthening the primary health care system. In 2026, a bill will be introduced to the Legislative Council to confer power on the PHCC, the Primary Healthcare Commission, and to set up a network and regulate the use of resources and the provision of services. We will be enhancing the family medicine outpatient clinic service, and in this policy address it has been announced that the FMOP outpatient clinic services will be extended to provide screening and care services for the members of the public, and the volume of service will be increased, and the service hours, extended service hours, will be regularized to address the demand for primary health care service on the part of the grassroots people. Also, in order to enhance the effectiveness of the chronic diseases control, we will extend the CDCC platform And we will turn this into a CDCC platform so that we can incorporate more control functions into the system. And hepatitis B screening will become the pilot scheme. And the platform will be expanded to cover the community drug formulary as well as the community pharmacies, so that the members of the public will be able to get affordable medication through the family physicians. And to enhance the primary health care, the PHCC will further develop the district health centers, and we will be consolidating the district elderly health centers as well as the DHC expresses. In Kwun Tong, the 3 DHC expresses will be consolidated in order to achieve better synergy and to roll out the DHCs in 18 districts in Hong Kong. In terms of oral health, we will be strengthening the public and subsidized oral health, and the dental hygienists will be providing education and also the risk assessment. In terms of cancer control, cancer is the #1 killer in Hong Kong. 35,000 new cases emerge each year, and 15,000 people lost their lives to cancer each year. And the government will be enhancing the leadership position in the treatment of cancer and optimize the services. We will strengthen the connectivity both in Hong Kong and outside Hong Kong. We will work with the National Cancer Center to work on the early intervention and the utilization of big data. We're pleased that the 2026 World Cancer Congress will be taking place in Hong Kong. The government will be giving full support. There will be well over 3,000 specialists who will be congregating in Hong Kong for this Congress. And we will also be stepping up screening for cancer in 3 areas. The first one is cervical cancer screening. The pilot HPV testing of self-collected samples will be expanded from the MCHC to the PHCC network. Second, we will strengthen the lung cancer screening. The tertiary institutions will be deploying AI for this exercise. Third, as I said just a moment ago, through the hepatitis B screening program, we will follow up on the hepatitis patients to guard against cancer. We will strengthen the treatment and diagnosis of cancer. We will step up the genetic testing. There will be targeted medication in order to achieve the best possible efficacy and to minimize the side effects. We will take advantage of the cancer data and the resources to boost the oncology study and to translate the research results into medication. We will adopt the 1+ mechanism to speed up the approval for drugs to be incorporated into the drug formulary. The service one will be increased and equipment will be procured to meet the demand arising from cancer cases. We will also introduce the non-locally trained healthcare workers like the diagnostic and therapeutic radiographers. The low-risk, stable cancer survivors will be transferred from the specialist care to primary care, and to unleash the potential of the primary health care so that the specialist care resources can be focused on the new emerging cases. For end-of-life care, the advanced decision on life-sustaining treatment ordinance will be kicking in next year, and we are making preparation for that. And we are conducting training for the relevant organization and updating the relevant guidelines, and also to promote more proactively this idea of advanced decision, and also enhance the end-of-life care, like the palliative care, and also make arrangement for patients to live out their years in their homes. We have been promoting the development of Chinese medicine and to foster the internationalization of Chinese medicine. Before the end of the year, we will be promulgating the blueprint for Chinese medicine development. This will cover the clinical services and the quality of Chinese medicine at the international standard, and the innovation, the culture of Chinese medicine, and also the internationalization of Chinese medicine. The Chinese Medicine Hospital will be coming into operation, and there will be specialist care, including the internal medicine, external gynecology, pediatrics, orthopedics, and acupuncture, as well as 12 different specialties. We will be fostering the sharing of the EHR records, and there will be integration between Chinese and Western medicine, and expand in the osteoarthritis treatment and palliative care. In December this year, we will be hosting the GPA conference on inheritance, innovation, and development of the TCM. The experts will be brought together in Hong Kong from the GPA and other parts of the globe to discuss this very issue. For mental health, we will be taking advantage of the Health Workplace Charter to let people receive more training in terms of mental health care, and we will be giving recognition to those who are making contribution in this area. In view of the concerns of the screen time on the part of the children and adolescents, the DH will be updating all the relevant guidelines to review the latest scientific evidence.
So as to get an understanding of the impact of the use of social media on the health and well-being of children and adolescents. There will also be recommendations to ensure their healthy development. At the moment, there are 3 district health centers that provides assessment and follow-up on mental well-being for free under the Healthy Mind pilot project. It will be extended to 9 DHCs so that those with the relevant training and background will provide follow-up services. We will also leverage on technology to optimize mental health services, including the psychiatric day hospital and outreach services. Telehealth services will be strengthened to provide options for patients. We will also formulate the stepped care model. Those at the front line will deal with general emotional issues, and for more serious cases, there will be follow-up services provided by our professionals. We will complete the formulation of this step care model on mental health by the end of this year. On International Health and Medical Innovation Hub, in 2023, the hub was proposed in the policy address. The goal is to promote industrial development, that is the development of life and health industry, as well as allowing patients advanced treatment and care. And we will submit the relevant bill to the Legislative Council within this year so as to advance regulation on medical products, and we will also step up the process in to establish the primary evaluation mechanism. We'll speed up the approval of 1+ mechanism so that innovative drugs recommended by the hospital authority will be given priority in the evaluation and approval process, and we will implement the primary evaluation for new drugs in phases starting from 2026. We understand fully that clinical trials are crucial to promoting the robust development of the life and health industry, and we will actively enhance patient recruitment and trial efficiency. And in fact, the Greater Bay Area Clinical Trial Collaboration Platform was commissioned in November 2024 together with the Clinical Trial Center in Shenzhen Park. Adopting this one zone, one park, two zones principle, we will set up this platform to conduct studies on high-end cancer drugs as well as other advanced medical products. And we will also establish a Greater Bay Area real-world data platform so as to provide valuable data on the use of these drugs so that they can be made available in the market as quickly as possible. In order to promote the long-term development of the clinical trial ecosystem, we are preparing to establish an international clinical trials academy so as to train professionals. This will provide support for healthcare manpower, and we will also deepen collaboration with the R&D and institutions and academic sectors so as to provide more training opportunities and facilitate the exchange of talents. The hospital authority will also set up an office for introducing innovative drugs and medical devices so as to promote the application of innovative drugs and medical technologies in Hong Kong. There are also other measures. For example, we will strengthen professional regulation of healthcare services. For unscrupulous practitioners adopting certain medical titles or descriptions, thereby misleading the public, we will progressively implement Section 92 of the Private Healthcare Facilities Ordinance so as to prohibit the use of specified titles or descriptions by premises that are not approved institutions under the ordinance. The government will consult the stakeholders in a timely manner so as to provide a more comprehensive coverage of these titles or descriptions. In terms of ambulance transfers, with the staunch support of our country and the provincial government, so we will collaborate with the Guangdong provincial government as well as the municipal government of Shenzhen to further expand the cross-boundary patient transfer by ambulance in the Greater Bay Area. The scheme will be extended to cover designated hospitals in Zhuhai and Nansha so as to benefit more residents in the Greater Bay Area. We also support the government's initiative in encouraging childbearing. There will be relevant measures. For example, there will be collaboration between the mother-child care health centers and also the relevant departments under HA so as to provide a comprehensive scheme. There will also be some friendly measures for expectant mothers. That means dedicated care counters will be set up. The Primary Healthcare Commission, together with the Hong Kong Family Planning Association and the MCHC of the Department of Health, and also GNO specialty of HA, will provide stepped-up services so as to enhance the confidence and capability of expectant mothers in caring for themselves as well as their newborns. On assistive reproductive service, the relevant subsidiary legislation has been amended to scrap the statutory storage period for gametes and embryos for self-use. It will take effect on the 1st of December. And the HA will continue to increase the quotas for assisted reproductive service to 1,500 this year. That ends my presentation, and we'll be happy to take questions from the floor. Thank you. Now the floor is now open. If you want to speak, please speak into the microphone provided, and please introduce the outlet you represent. Please ask not more than 2 questions. This gentleman. I'm from TMHK. My question is on the 3-tiered emergency mechanism. It will be regularized. Can you tell us how effective it is? For the cases referred by schools, how many of them are categorized as serious? And that I understand this pilot scheme will be extended to primary schools. Is it because of the deteriorating situation of mental health among young people? And also the shortening of waiting time for the specialty of surgery by 10%. Can you tell us specifically how many weeks for other specialties will be shortened, and will locum doctors be recruited? The government attaches great importance to the mental health of children and adolescents. According to the policy address, the government's goal is to implement early identification, intervention, and treatment. I want to emphasize that we place a lot of emphasis on prevention. There are some key areas such as family, schools, personal relationships. These are crucial to anyone's mental well-being. We have a 3-tier mechanism comprising the Education Bureau, Social Welfare Department, schools, as well as the Health Bureau. So there is collaboration among these parties. We want to encourage schools and parents and members of the community to work together so as to help us provide cross-disciplinary support and identify and support students at risk. This mechanism was put in place in December 2023. On the 1st of November 2024, we enhanced this mechanism. As for effectiveness, we've entrusted the university to gauge the effectiveness. The study was completed in the 4th quarter of 2025, and according to the preliminary findings, schools in general welcome this mechanism. For students with mental health issues who are identified, they find the mechanism really helpful. Now let me share with you some data. Starting from the 1st of November 2024 to the 31st of August 2025, after optimizing this mechanism, and I'm talking about the 2nd tier, namely, if necessary, schools will seek support from outreach support teams outside of the schools, and that cross-disciplinary support will be provided to students identified. Referrals will be made to the Social Welfare Department. Altogether, 287 such cases were recorded. And that means the cross-disciplinary support teams followed up on these cases. As for the 3rd tier, that is the referral from a school principal to the HA's psychiatric department, 114 cases were recorded. 7% of these cases were urgent cases, 57% were semi-urgent cases. The rest were stable cases. So I cite these figures to explain to you that we need a collaborative effort from all walks of society, and only a minority of these cases required services from the HA.
Right, thank you very much. As to the new case waiting time, the hospital authority will be on a regular basis reviewing the waiting time for the specialist care. For each care, there are 3 queues And the first one is the emergency service. Second is the semi-urgent. The third queue is for the stable. Now, for the urgent and semi-urgent, we will cover them within 1 to 4 weeks. And this is measuring up to our standards. Now, for urgent and semi-urgent cases, we're able to see them within the specified time. Where we can make more improvement is the waiting time for the stable new cases. Now, we have 8 disciplines reviewing the cases. You probably heard before that we did have measures to reduce the waiting time for new cases, for ENT, and so on. In 24-25, for surgery cases, the waiting time is 90 weeks or more. This is undesirable. For specialist outpatient services at the upstream, we will look at the cases. If they don't need any specialist care, they can be dealt with the primary health care, or they can be triaged by the nurses. At the downstream, for all cases that are stable, they don't really need to be seen at the specialist outpatient. The cases can be closed and referred to the primary health care, or they can be referred to the nurses for follow-up, and that would free up more time for the new cases. And we will certainly look at these triage cases to see how best that they can be dealt with. We have a number of measures. We can increase the manpower, increase the service capacity, and for specialist outpatient services, there is always room for ramping up the efficiency. We're working hard on different fronts to make sure that we can minimize the waiting time for these new case specialist care. Gentleman in white over there, please. Mingpao Daily. Let's put a question about the 1+ mechanism for new drugs. That this express channel will be faster than 150 days. Now, in fact, how much faster can this be? Will you have the resources available to tie in with this? Will this fast-track mechanism be extended to the first tier system in 2026? Also, about the fast-track progress when the patients in critical conditions need medication, how are you going to be activating the fast-track? And the pharmaceutical companies, if they do not make the application, will you be able to get the innovative drugs? In other parts of the world, they would accept a certain medication that doesn't even have the clinical data. Are you going to be following this practice? And also a drug safety net? And you'd like to incorporate more new drugs, but I don't think we have seen any specific target as to how many new drugs that you will be incorporating in the budget previously. There would be hundreds of millions of dollars that would be devoted to this. In terms of safety net, would you be elaborating more on this, please? Secretary, please. Let me deal with this conceptually first, and Dr. Lam from the DH will flesh out the details. Now, for the 1+ mechanism, we aim to have a decision taken within 150 days. We would like to ramp up the speed as much as possible. We also like to create a fast-track approval mechanism. This is the medication that would be urgently needed clinically. It may be in absence of any alternatives, and there is also a time-critical kind of illness. It would measure up to these requirements. They would have considerations like this in other parts of the world as well, and we would have a fast-track approval, and priority will be accorded to these cases, and they will be different from other kinds of approval. But we have to emphasize that this will not impinge on the quality Now, you mentioned similar cases in other parts of the world, that there is the designated patient medication application. It depends very much on the physicians that encounter cases in which the existing medication will not help, and there is medication that has not been registered, and the physicians will be bearing the responsibility. We do have the existing mechanism, but it's not desirable for the doctors to bear the responsibility. We'd like to introduce this fast-track approach so that we can formalize this fast-track approval mechanism. Dr. Lam will flesh out the skeleton with more details about the kind of medication and also the time frame and so on. You mentioned the safety net a moment ago. That since the 1+ mechanism was introduced on December 1st, 2023, 14 innovative drugs have cleared the 1+ mechanism. This has been much faster than before. Before we need to have 2 authoritative organizations endorsement before they can be used in Hong Kong. Now, for these 14 drugs, half of them have been incorporated into the drug formulary, and they have been incorporated into the safety net, and some of them have been incorporated into the list for specialist care. And patients can have access to these kind of specialist drugs for $15. And Dr. Lam can fill you in on the details about the fast-track approach. This 1+ mechanism is the first step, and it is also an important element for the control of drugs. As the Secretary said, we have introduced 1+ mechanism for more than a year now, and 14 innovative drugs covering cancer, hepatology, chronic diseases have been incorporated into the system. As a next step, we will be taking stock of the experience over the past year, and for drugs that are critical for treatment and for drugs that would be important for rare diseases, and also for drugs that would be needed for public emergency. And we'd like to take advantage of this 1+ mechanism and offer the fast-track approach. So we have this fast-track pathway that would cover certain specific kinds of drugs, as the Secretary mentioned. Now, for these innovative drugs, these are wonderful drugs. They should be incorporated into the drug formulary, according to many people. So in this fast-track pathway, we will be coordinating with the hospital authority. And if there are important innovative drugs that are critical for the treatment of certain diseases or for rare diseases, for drugs like these, after the hospital authority has reviewed this and it is considered important for public health, we would be taking advantage of this fast-track approach under the 1+ mechanism to fast-track the assessment of these drugs. Now, under these circumstances, at the moment, under the 1+ mechanism, we have a time frame of 150 days, and we are able to measure up to this time frame regionally and globally, and this is really not bad at all. After reviewing the situation, it is our target to aim to achieve 100 days for the fast-track approval of the innovative drugs. We hope this can be completed within 100 days.
However, I must emphasize that we are still in the process of accumulating more experience whilst migrating towards primary evaluation. So we need to have regard to the clinical pathways, complexity, the number of applications. And after setting this target of 100 days, we will review the situation and see whether the time frame can be further shortened. Sorry, the speaker is not using a mic. All right, please let another reporter a chance to speak. This gentleman in white. I'm from AM 730. I'd like to ask about cross-boundary ambulance transfer. It will be rolled out in a progressive manner. And what about a two-way transfer? When will it be introduced? Does it mean that the Fire Services Department or the Hospital Authority will first dispatch ambulances to the mainland? Is it necessary to get a license from, in the mainland? About cancer prevention screening services, you talked about enhancing service capacity. Can you tell us by how much? And in terms of waiting time, how will it be shortened? Will there be any priority to certain types of cancer in allocating resources? Is HA capable of meeting the enhancement in service capacity with the resources available? Well, about the cross-boundary ambulance transfer, last year we introduced a pilot, and that is from this hospital in Macau and the Hong Kong Yu Shenzhen Hospital in Shenzhen. Ambulances were dispatched for transfer of patients across a boundary. Last year, we had 16 cases. 11 patients were transferred from Shenzhen to Hong Kong and 5 from Macau to Hong Kong. Now, we believe time is ripe to consider expansion of this scheme by introducing more service points, and we are now considering Zhuhai as well as Nansha in the Greater Bay Area. These are two places close to the West Coast with higher demand. About two-way ambulance transfers, we don't see great demand, but still we see the need of two-way transfers. Some patients may need to be sent from Hong Kong back to Macau or to the mainland. Our plan is to allow ambulances to go from one hospital to another in a point-to-point manner so as to expedite the rollout. If other vehicles or manpower are involved, this may slow down the process. We want to roll out the two-way transfer as quickly as possible, and this is the quickest option. We will give priority to this option. In terms of approval of vehicles, personnel, as well as drugs, medical devices, etc., we want to work on the existing basis. And if there is a need for patients in Hong Kong to be sent back to the mainland in the Greater Bay Area or Macau, otherwise we will adopt this option. Dr. Lee will take the next one. About cancer services. In 2024-25, there were 164,200 cancer patients receiving services under the hospital authority. So that's about the figure, taking into account new cases, including patients passing away. Now, our cancer prevention screening strategy includes not only prevention screening, but also diagnosis, treatment, rehabilitation. The hospital authority places emphasis on the latest steps, including treatment, rehabilitation. We anticipate more and more cancer cases, and that is why we need to come up with ways so as to follow up on these highly subsidized cases in a more precise manner. For example, in terms of diagnosis, we want to introduce new diagnostic methods such as gene therapy, and we want to be able to conduct genetic testing so that we'll be able to better identify the diseases. In the past, without genetic testing, we couldn't do it precisely, and a patient would need to receive chemotherapy, and that may not be precise enough. If we have genetic testing, it will help us advance precision medicine. The second point is that we are now relying more and more on ambulatory procedures. Under this daycare model, there is no need to receive patients in hospitals, and we expect to increase the number of attendances, and we'll also increase the service quota for chemotherapy up to 5,000. There will also be more sessions in operating theaters so that the needy cancer patients can receive the necessary services. There will also be 14,000 genetic testing quotas available. Now, for cancer cases, after surgery, a patient may still need to undergo chemotherapy, etc., followed by rehabilitation, and according to medical literature, we want to improve service delivery and optimize service workflow to help patients. For example, we've been providing case management services for patients suffering from urological cancer. And then the final step is rehabilitation. We want to make sure the case is fully remitted, and we will work with the Primary Healthcare Commission for stable cases, including patients suffering from prostate cancer or thyroid cancer. If their conditions are stable, they can receive follow-up treatment at the primary healthcare level so that we can have capacity to take up more patients. Next question, this lady in black.
First question, why has cancer become one of the key focuses in the health chapter of the policy address? Is there a specific target on reducing the cancer incidence rates? Second question, we saw that the government wished to promote the standardization of clinical data within the Greater Bay Area and establish a real-world data platform. Could you elaborate further how would that work? Like what types of data will be standardized, and does that mean the mainland will now follow the Hong Kong standard, and why would they do so? How would this benefit patients in Hong Kong? Thank you.
Okay, may I invite Professor Low to answer the second questions, and then Dr. Lee for the first question.
Well, the reason that we include cancer into a theme in the policy address this year is that the incidence of cancer is rising, rapidly rising. And in fact, we all know that cancer is the #1 killer in Hong Kong. And over the last 30 years, the cancer incidence has actually doubled and is still increasing by roughly about 2.4% per year. We have over 35,000 cases a year in the year 2022, and with close to 15,000 deaths from cancer. While we have an increasing incidence, we are also having some successful measures to improve the outcome of these patients. The 5-year survival rate has actually increased over the last 20 years from 42% to 55%. This is an indication that we are successful in treating cancer. But it has now become a more chronic disease problem. Remember, in the past, cancer is usually regarded as an incurable disease, and most patients will not have much effective treatment. But now we have more effective treatment, and many patients are actually surviving with cancer. And cancer has become almost like a chronic disease for us to handle, and it's a huge burden for the patient, for the family, and for the whole healthcare system in Hong Kong, and for the whole society. The number of cancer survivors, these are patients who have cancer over the last 20 years, and they are still surviving in our community, amounts to close to 250,000. That's not a small number, especially for those who are over the age of 75. 1 out of 4 would have a history of cancer. So that's why it's very important for us to deal with this important health issue, from prevention to early detection, to treatment, to rehabilitation, and also for the end-of-life care for these patients. That, as for the target that you mentioned, in fact, we have many parameters in terms of the every measure in the policy address. We will be, for example, we'll be going into the screening for hepatitis B patients. We will get high-risk population for screening for hepatitis B because this is the #1 cause for liver cancer. And with the pickup of these asymptomatic hepatitis B carrier, we will start a screening program to treat their hepatitis B so as to prevent cancer, and at the same time institute a screening program for the early detection of liver cancer. We will have a target number, and for lung cancer as well, we will institute a pilot scheme to study the use of AI to assist in the CT detection of early lung cancer. Because while we are successful in preventing smoking-related squamous cell carcinoma of the lung, the incidence of adenocarcinoma, which is a completely different category of lung cancer, is rising. And there is a need to have measures to detect this disease early, because we all know that early detection means a lot in the outcome of these patients.
Okay, so you must have heard about data is the next oil. So in the future development of innovations, including clinical trials or using the big data to inform, policies or to do modeling, basically the key point is to have a very standardized data. The data must be cleansed, must be informative, they should be correct, and they are retrievable, consistent, and the way that we capture it and the way that we enter the data must be standardized in order to make the data meaningful. So that's why the reason why we have to standardize the data. And how we actually benefit the patient in two ways. With the data is how we actually use the data. I would say if you do big data analysis, we can do analysis and predictive modeling. For analysis, you draw all the data together. Given that data are informative, cleansed, and accurate, we can do accurate analysis. Just like what Professor Low just mentioned about when we use the low CT dose lung, basically we're collecting all this informative data and doing the analysis. But one more step, we want to do the predictive modeling. For example, if we know all the disease condition of patient, basically we can predict the survival rate. We can predict what other complications will happen in certain kind of years. So all of this, that technology can reduce the mortality and morbidity of the patients, can do more preventive measures. It will all depends on the accuracy of this data. And the second part is facilitate a clinical trial. If the data is not correct, basically all the clinical trial will not be beneficial, and even for the innovation of new drugs will not be informative. And so in order for Hong Kong biotechnology to develop, data will be the first step.
I want to supplement a little bit about the real-world data, real-world study. Real-world data is very important for not just for our understanding of the effect, efficacy, and the long-term effect of many new medications which has been marketed. So post-marketing data is really important. It's also important for pharmaceutical companies in the future development as well. So in that sense, want to highlight that recently a pharmaceutical company, GSK, has signed an agreement with our Greater Bay Area International Clinical Trial Institute to start real-world study. And this is a very important move, signifying that these pharmaceutical industries, they are interested in this real-world data, especially with the very standard and large volume of longitudinal data that we have in our public healthcare system, with the over 11 million patient data in the record. Thank you.
好，下一個問題。
Next question, please. Gentleman over there, please. Now TV. In this policy address, there are many measures mentioned that are ongoing. There doesn't seem to be any attempt to allocate resources. Now, are you concerned that a lot of resources devoted to North Metropolis at the expense of the medical health care. Now, the fees and charges will go up next year. Are you concerned about this? Secretary? Thank you for your question. In terms of healthcare policy, I don't think things can be completed within a year. Like an international innovative medical hub, it was announced in 2023 that would involve a long-term reform. The medical products review that we've set to the CMPR, and we need to have the clinical trial. In many parts of the world, it would take anything up to 10 years for things to be done. So we will be progressively rolling out these measures. That to take the 1+ mechanism, for example, we are taking one step at a time in reforming the evaluation of medication. In this year's policy address, we are continuously taking forward the existing measures like the healthcare reform, the International Medical Innovative Hub. We are taking a step at a time. You mentioned the healthcare resources. Resources are finite, always finite. They're never sufficient. But as we said, we have to optimize the resources in a way that we can have targeted approach. I must emphasize that in the revision of fees and charges, we're not merely putting up the charges. There are things that will go up. There are things that will go down in prices. We have 3 specific measures where we would be providing more subsidies, more of a safety net for the needy patients, for the poor, the critical patients, the poor, the acute, the serious, and the critical patients. So we should not really blindly seek resources. If you do not optimize the existing resources, if you throw more resources at the issue, it will be a wasteful use of the resources. We have to use this judiciously.
Last 2 questions. This lady in a black jacket. I'm from Economic Times. I have a question about 1+. For the fast-track arrangement, will there be consideration of the country of origin or the type of drugs? Because another reporter asked about the possible fast-track arrangement for 1+ mechanism as well. So are you going to tell us that it is already fast enough and there is no need to introduce a fast-track arrangement? And can you tell us about the bill to be introduced, empowering the PHC? Can you tell us what indicators we put in place? Will it be about the feedback or waiting time? And after the bill has been passed, how will efficiency be enhanced? Secretary will take the first question about 1+, and the Secretary will take the question about primary care. About the drug approval mechanism, be it the primary evaluation or 1+ evaluation mechanism, a fast-track arrangement will be put in place to cope with some urgent situations. Even for primary evaluation, there is a need to have fast-track arrangements. For example, the emergence of a novel infectious disease such as COVID-19, which sparked a global pandemic, and that vaccines were developed. A fast-track arrangement was put in place for approving the use of such vaccines because this pandemic came as a tsunami for the world. We had to come up with the best way to cope with this clinical emergency. So against this backdrop, a mechanism should be put in place to approve the use of such medicine quickly. We have the 1+ mechanism And in the future, after rolling out primary evaluation, at the appropriate juncture, we will consider rolling out a similar fast-track arrangements as well. Now, coming back to the existing mechanism, of course, this is not what I want to happen, but if something like COVID-19 happens again, we will have to adopt a fast-track approach in order to cope with a public health emergency. Now, about the primary care services, in 2026, we will table a bill into the Legislative Council to empower the Primary Healthcare Commission to draw up standards that will apply to primary healthcare providers across the territory. The establishment of the Primary Healthcare Commission is to set up as a mechanism so as to regulate the standards and services provided by primary healthcare service providers, as well as the training of relevant professionals. We need to give the Primary Healthcare Commission statutory powers so that, if need be, the Commission can follow up on matters such as service quality. And in the long run, this Commission can ensure service quality of the primary healthcare service providers. And we also go by some standards such as the Register for Service Providers, etc., for the purpose of quality assurance. Last question, this gentleman in the fourth row. Good afternoon, I'm from Commercial Radio. Another question on primary healthcare services. I understand that the chronic disease co-care platform will be launched on the basis of the chronic disease co-care pilot program. I understand that you've received positive feedback from this pilot project, but the positive feedback has come mostly from patients and their family members, but not doctors. Now, about this platform to be set up, is it possible that doctors may not be able to cope with the demand? And about mental health, I understand the Department of Health will revise the guidelines on the screen time and use of social media by children and adolescents. I'd like to have more information on this, because nowadays children are very much used to using social media. So will the guidelines be useful in promoting mental health? I'm the Secretary to take the question on primary health care, and then the Director will take the question on the revised guidelines. Now, about the chronic disease co-care pilot scheme, as you mentioned, we will include more and more diseases for the purpose of screening and management, and then we will also integrate with a district health network, and together with a family doctor scheme, we will continue to promote primary health care, and that includes community drug formulary and the pharmacy program as well. Now, you ask about doctors' participation. In fact, as at the end of August, 730 doctors already joined this pilot project. Some doctors are also participants of the public-private partnership program, and they will be invited to join this chronic disease co-care pilot scheme as well. I believe that with more doctors joining, there will be a wider participation by the public as well. Director, we understand that children and adolescents' mental well-being is very much affected by screen time as well as the use of social media. And we see some worrying trend from the data collected. First, over 60% of students use electronic screens for more than 2 hours a day, and that's above the WHO guidelines. 10% of students stared at the screens for so long, such that they missed school or they missed other social activities. 3% of students suffered from cyberbullying in the past year. Prolonged use of electronic devices would impact on the physical and mental well-being of our children, such as lack of exercise, leading to overweight and obesity among children. And long screen time would also affect younger children, such as their attention span and emotional control. In 2018, we revised the guidelines. According to this revised guideline, there are recommendations. For example, we don't recommend children below the age of 2 to use any electronic screen devices. But times have changed. People nowadays not only use electronic devices, they also frequently use social media. There are pros and cons on using social media. The social media could help young people build their circle and train their empathy, but at the same time there are problems such as cyberbullying. And we must not ignore these problems. As I mentioned, according to data collected, indeed, screen time and social media do have an impact on our young people. So time is ripe to consider the scientific data. And that is why we will establish an expert panel. This panel will comprise educators, specialists, as well as other professionals. Concerted efforts will be made to make recommendations on promoting healthy use of e-screens among children and adolescents, as well as the use of social media, so as to strike a balance and ensure their physical and mental health. We hope that this expert panel will convene the first meeting before the end of this year. Of course, the purpose is to formulate the guidelines, and that we can take forward the set of guidelines at different levels. Say, in different scenarios, such as school campuses, how the guidelines can be applied to promote mental health. Another point is that last year we launched a scheme about health at school, and so far 800 secondary and primary schools have signed up. And we also have a school-based health promotion scheme covering not only physical activities, balanced diet, but also mental health as well as social activities. So on this basis, with the revised guidelines, there will be guidance provided on how health should be promoted in schools. In fact, we announced this year that we will launch a scheme called One Health Report per School. That is, we'll review the relevant health data for each school to see, to look for areas of improvement. For example, if students in that school tend to be overweight or obese, and then we'll have to work with the schools to find a way of handling this problem. And based on the guidelines, we can then monitor the data provided by schools on mental health, and that we can further promote mental health in schools for protecting the next generation. That's the end of the press conference. Thank you.